May I request now Dr. Vijendra Ed sir and Dr. N. Dhanpal sir for our next session, that is Dr. Joe V. Desa Memorial Oration.
Hello, good afternoon, all the delegates. Once again, as a chairman, I welcome each and everyone for this jubilant Platinum Jubilee 2024 AOICON conference. Now, Dr. Seemab Shaikh is going to deliver the most prestigious oration lecture, that is Sandra Disa Oration Lecture. It is so great honor that Madam Sandra Disa, at the age of 92, she has made to attend this conference. That is a very great honor. All of you, please give a big hand for Madam Sandra Disa. She has made it standing ovation you can give. At the age of 92, it's so much of difficult. She has made it to come, and that is the gratefulness of such a wonderful president, past president of our association. This oration is the most prestigious oration, and now it is going to be delivered by none other than Dr. Seemab Shaikh. So, podium is yours. Please take over.
Thank you. Thank you, sir. Thank you very much. It's a great honor to be here, a great privilege. Thank you very much, Team AOICON 2024. And the privilege is even enhanced with Madam's presence here. And thank you so much, Madam, for being here. Because it's not just about you being a great teacher to all of us, but the culture that you promote where we need to look into our parents and continue giving them respect posthumously also is something which I think is really worth respect. Total respect to you, Madam. Good afternoon, everybody. All the media, I have permission to be putting it there. Nothing to disclose. And my presentation today will be in complete accordance with the current NMC guidelines. Dr. Joe Desa was with us between 1915 to 1989, and he, during the World War, was studying himself at Johns Hopkins. He had very many appointments. He was the head of the St. G.S. Medical College. He was a consultant at Suri Petit Parsi Hospital, and was the ENT advisor to the Armed Medical Forces of India. He's got a lot of research published and 2 books published by him also. And he was a member of Corels as well as the president of our prestigious AOI body. And he was known as the, okay, so he was known as the father of the micro-ear surgery and the micro-laryngeal surgery and neurotology in India. And it gives me great pleasure at the 75th Platinum Jubilee event of ours, of our esteemed body, to be giving this oration in his memorial. And today I'm going to be talking to you about the right surgery and the right patient in OSA. And my narrative would be very simply to felicitate easy decision making. And I'm going to be extremely evidence-based about it in the adult OSA patients. And the reason I say this is because I think we need to now grow out of this attitude where we say that, oh, this works very well in my hands. Perfectly, it works very well in our hands, but we should be aware of what the evidence is out there that says about what we do. So all our seniors, we grew up with teachers who were doing this universal procedure. It was a UP3 that was done. And this procedure was doing wonderfully well. The surgeons were happy, the patients were happy. There was no problem with this procedure. Till a time came when Sher et al. Came up and with the classification of sleep apnea, and they gave AHI indices. And then they told us that, listen, your surgeries don't seem to be working very well because it's not fitting in the indexes. So this was physicians telling us, and this is not about a fight between physicians or surgeons. This is just about understanding the concepts and why things changed, because that's what woke up the ENT fraternity to start thinking as to how we need to change our approach to the field of OSA. And lots has changed in the past 2 decades. Our attitude has changed towards evaluation. Our surgeries have changed. The biggest plus point that has happened is the consolidated armamentarium. So now we don't have a huge list where we kept saying, oh, this is better, that is better, this works for me, that works for me. We've got a very consolidated armamentarium of 1 or 2 surgeries which work wonderfully well. And we have a much more patient-centric approach now. So it's not about the surgeon, it's not about the surgeon's skills, it's not about what he wants to do. It's a patient-centric approach where we are now changing the criteria of success. I use the word changing because we are somewhere yet to blame for being unable to publish that out there and show them the criteria of success differs for us. So, but it is changing and we are going to get there. So this is how we evolved. We looked at a patient in the OPD, we did PSG, we were told that PhDs are not very well read, so we went in depth trying to read positional changes, trying to read RARAs, trying to read so many other things and try to impress upon them that we understand what PhD is all about. We learned about DICE, we learned about dynamic MRI, then we were told that DICE is not telling us at what level of sleep you're having the problem, so we went ahead with DICE with BIS, we did the advanced DICE, we did interventional DICE, and then we came up with a patient-centric approach. But if we were to choose the right patient, the first thing would be the somnography reports. So the PSG reports, and based on that, if it's a non-central OSA, that's where we probably come into the picture. And we only need to know less things now from the PSG, which we otherwise thought we wanted to know a hell of a lot out of that PSG. And the AHI based on which we classified the entire OSA is something that doesn't matter to us very much today, because it is the anatomical obstruction which if I'm able to remove, it doesn't matter to me if the AHI is 100. But that identification of those factors is what makes things different. And then we have patient factors which I'll dwell on later. So if you were to think very systematically, right from the nose down to the glottis, every possible place that you find an obstruction, you've got to deal with it. That's where the right surgery will come in, depending on whether you want to do it in a single stage or a multiple stage. But I think the important factor here is the when. The optimal BMI is like having your patient in a situation where he will respond to the work that you're doing. And that's why amongst the OSA circles, we have a kind of a trait where we say, it's more about let the patient earn his surgery. Don't just go ahead and do the surgery because he's there with you in your chamber. And of course, a lot of patient logistics come in. So let me not waste time for this august audience to be telling them about turbinates and septoplasty. This is something that we all know. The difference being that if you do a CT scan and you find out it's a more cavernous tissue issue, then you can decide to either RF it, coagulate it, or then go ahead and excise it, do Swiss roll, whatever you want. And then we know that septoplasty is a decision which we make otherwise also very regularly. The next level would be an SP fold, and the more sensible thing to do here is to use a coagulation channeling and not an RF, because RF still disperses energy laterally where the carotids are there. So you use a coagulation which has got even the water to kind of reduce that thermal damage. Again, I will not dwell too much into the tonsils and adenoids. It's like no-brainer. Everybody knows how to deal with it. And the famous statement, as always, that it's the man behind the tool that matters. A man with a fool with a tool is of no use. So figure out which one of these you do, and you do a tonsil and adenoid. But the problems came when we were dealing with the palate. Now this is where the decision making was always an issue. So first concept to understand is the concept of the bony box versus the soft tissue. So if you have a small bony box, any kind of soft tissue work you do here is going to fail. But that does not mean that when you find a bony box issue, you should also consider expanding that bony box before you do the next step. And this is where the major role of our orthodontics and the pediatric dentists and the entire dental community comes in. So you have a distraction osteogenesis maxillary expansion that is done, and unless and until you remove or you widen the floor of this nasal cavity, even the nasal work that you do is not going to help. So you have something like this which you see gets very easily and well expanded. You can see the expansion levels there. And this is non-invasive. Now this is one of the major things that can be done under the age of 12, 13 pediatric OSA, but at the same time, if you need to do it in an adult, it's called the surgically assisted rapid maxillary expansion, a SARME, where you just take a cut in between and then use the same things to divert it. The other points you need to consider is whether you have an oblique palate or whether you have a vertical palate, because in this kind of an oblique palate, if you don't do excision or reconstruction, nothing is going to work. But if you have a vertical palate like this, then you don't really need to do any reconstruction or excision. So you do something very simple like a somnoplasty when you have to have a vertical palate, which is very simple. I don't think I should play such videos also. But the point is you have multiple lesions on either side of the palate, and these will help the whole palate shrink over a period of time. So this is very simple. Done with RF, you can also use coblation channeling. But the biggest thing is that you don't find ideally vertical palates at all. The more work you do, these are the kinds of palates that you will find. They will be always sloping. There will be an anterior-posterior collapse, or there will be a lateral collapse or a complete concentric collapse. Which is why this was the whole armamentarium that we had. So if you look at just a simple anterior palatoplasty, this is nothing but a simple procedure where you take a rectangular box 1 centimeter with the base of the uvula, 1 centimeter on either side of the midline, and the length of the rectangle is also about 1 centimeter. So in this rectangular box, all you do is remove the mucosa, remove the submucosa, and then suture it in 2 layers, which pulls the anterior part of the uvula and the palate forward. That being done, a zeta palatoplasty is a very specific indication. See the palate, it will be falling onto your posterior pharyngeal wall, and this is a thick palate. So a thick palate with a fall completely onto the posterior wall, all you do is cut the palate open through and through like a book and suture it on these 2 sides of the butterfly. That is as simple as it is for a zeta palatoplasty. Now, having anterior palatoplasty out, having the zeta out, we are left with what was there earlier. This is what we used to do. And this is something which I also gave up almost 18 years back. We all know why this has failed. The fibrosis doesn't stay, it becomes floppy, the CPAPs don't work. So that also, along with its modifications, are out. So why this confusing terminology now? Relocation, expansion, barbed. What was relocation? The day we really figured it out, that it's only the palatopharyngeus muscle which is there at the lateral part of the pharyngeal wall, and that has to move laterally. That's how the whole thing will happen. So you picked up the palatopharyngeus and sutured it onto the soft palate, but found that it was probably not enough. So you looked for another structure, which is the pterygoid hamulus, a little more laterally, and you brought that onto the pterygoid hamulus. Again, didn't last very well, didn't do that well. So then Claudio Vicini came up with the idea of putting it across onto the pterygomandibular raphe. So you picked up the palatopharyngeus and brought it up on the pterygomandibular raphe. So you see how the lateralization is processed. So you have a vertical expansion of the lateral wall of the pharynx. And let's understand the concept or where the palatopharyngeus is. You have volume on this, please. So that's the palatopharyngeus muscle.
And as you go in here and you see where the palatopharyngeus is, it is the posterior pillar of the tonsillar bed, and this is your medial pterygoid plate, and this is where
here will be your
the
medial
pterygomandibular
pterygomandibular
raphe
raphe.
starts from and goes all the way here. And when we are doing the barbed pharyngoplasty, the idea is to get this palatopharyngeus entirely onto the lateral
So
wall.
you can imagine the lateral shift that happens with this, if you understand that, and this is how I would do it. It's a very simple procedure, not a very rocket science kind of a thing. You take the palate, you take the barbed suture, get it across onto the pterygomandibular raphe, and I'm going to play this for a bit because this is something that you need to understand, and I will keep my time, Chairperson, sir. And then you take it across from there and you pick up the palatopharyngeus muscle after coming back again from there. You come out, pick up the palatopharyngeus muscle again. And you come back and pull it onto the pterygomandibular raphe again. Very simple procedure. This is absolutely something which even a first year or second year GR who's done tonsillectomies have done. Of course, tonsillectomy is a prerequisite for this procedure, otherwise you'll never get to the palatopharyngeus. And you see the pull that happens. See that lateral pull that happened over there. And when you repeat this procedure with 2-3 sutures picking up the palatopharyngeus along the way, the complete lateral expansion of the palate happens with this. So you see that pull, and you see how much of that lateral wall has expanded, and this gets done on both sides. Now what does this is by Claudio Vicini, and this addresses the entire vertical length of the lateral wall collapse. Now what does evidence have to say about this? This is a huge meta-analysis. Mean success rate of the single procedure 85.2, and this is also corroborated with a 10-year analysis. It's a systematic review. 10-year analysis, huge number of patients, 1,061 that underwent barbed reposition. So we call that as BRP, barbed reposition. And the success range increased from 65 to 93% of cases. Now it was not just about BRP being successful, it was also BRP versus the other pharyngoplasties that were being done. So it's not just, okay, my procedure is successful, this procedure versus the other expansion sphincters again proved the fact that BRP was far more successful than that. But there was one slight problem with this. This did not address the horizontal part of the palatal collapse, and that's when Marco came in. Marco is also from Italy, one of our colleagues. He started this around the same time, 14, 17, and what Marco did differently only was that this was the suturing that was done at the lateral wall of the pharynx, but he used another suture to go from one pterygomandibular raphe through the palate, out through the palate, second pterygomandibular raphe, and then come back and loop it. So all that he did was he suspended that palate. So he did the barb and then he added a suspension onto it. He called it and published this in 2019. This was the barb suspension pharyngoplasty called the BSP. Now the BSP obviously had much better results which he proved as compared to the BRP. So he had a barb suspension which gave you a result of almost 100% is what they've claimed, but much better cure rate than the BRP. That's what barb was all about, barb suspension was all about. And this particular procedure now addresses not the vertical length, but also the part of the palate. So a very big question that I've been bringing out everywhere across that I go, because DICE is being overused. People are just jumping into sleep studies and DICE without understanding. So the concept was that DICE was helping in change our decisions in sleep. But does it really do that? Was it really helping? The proponents of DICE would always talk about it this way. How can you do a sleep surgery without doing a sleep evaluation, right? Here's the evidence that goes to prove it. And this is an evidence which is multi-centered. Kenny from Singapore, Baptista from South America, Eva is from Poland, Itak is from Israel, Marina is from Spain, Srinivas is from India, Brian is from Canada. So it's like multi-centric all across, and then you have a huge number of patients where DICE did not show any surgical result. Now as academicians, if I am a lawyer who's prosecuting, I will give you evidence of prosecution. If I am a lawyer who's defending, I will give you defense. So let's keep this aside for a minute, okay? And we are intelligent people. Let's use logic. Let's use a simple bit of logic here. You did DICE, why? Because you wanted to find one, do one finding, do surgery A, finding 2, do surgery B, finding 3, surgery C. But now, all roads are leading to Rome. So whether it's finding 1, 2 or 3, you are doing the BSP as shown by Marco. So when all roads for the palate lead to this, then where is the question of trying to do a UP3, trying to do a relocation, trying to do a expansion? And this is evidence-based proof that I'm talking. And after this also, if we still keep talking about the fact that, oh, I do it this way, then I think we need a rethink coming there. Now, BARB was compared, BRP was compared with expansion and shown that it was better than any of these, and a BSP was shown to be way better than a BRP. So the jury is out there for you to understand that please do not land up doing a DICE as a standalone procedure before any surgery. Now, this is something that I would really like to percolate, because I see a lot of people just doing DICE left, right, and center. Think about it. Unless you are managing the patient as a single stage multi-level, somebody who's come from out of town, somebody who's a medical tourism, somebody where you need to know about the tongue base and epiglottis, then you go ahead and do a DICE. Maybe as a standalone also, that makes sense. There is where DICE is justified. It's also justified, let's say I'm doing a nasal procedure or an adenoid, and in that same GA I want to do a DICE, that's fine, that's fair enough, it makes sense that you're not subjecting the patient. But to do a standalone procedure of a DICE before embarking on palate surgeries does not make any sense. You are overkilling that workhorse. So what has changed now? We look at the PSG, but we look at only a few points. We don't go by the AHI that much. Of course, there are many other things in the PSG. I'm not underwriting the PSG off, but for practical purposes, we're doing less of that. We are not really rushing into this or even the dynamic MRIs because till the palate surgery levels. Please make a mark of the words that I use, till the palate surgery level. I'm not saying DICE is not to be done. I'm saying time it properly so that you get the best information out of it. If we were to come to tongue base, again it's a very rational way of looking at it. You have a high tongue base and a low tongue base. Unfortunately, there's no anatomically differentiating line that makes upper tongue base and lower tongue base separate. It's not there in Gray's Anatomy. It's a visual look. And the visual look helps us understand that it is it's logical that if you have to deal with this kind of a tongue base, you would rather go transoral. And if you're dealing with something below, you would go trans-neck. So if you're going transoral, you can either use the RF channeling or the coblation channeling or the coblation excision of that tongue base. And if you're going from somewhere below, then the hyoid suspension is what probably comes in to help you. So that also would be decided mostly on the patient choice after you have given him the entire lowdown of what you want to do and what results are expected. If you're entering into coblation tongue-base excision, then obviously your surgical expertise is definitely important for that and your backup issues. Hyoid suspension has lost a bit of its sheen because it doesn't give you that much expansion, and also the muscle tone gets lost after a couple of times. But that's when you counsel correctly, you will find that a lot of patients are willing to undergo the RF of the tongue base, and this is then very easily checked out post-operatively, and you can see the results that will be so much more better. So if you counsel correctly, and even if the patient is not willing for coblation excisions, you can still deal with that patient of tongue base along with other procedures that you can do. And needless to say, when you're dealing with an epiglottic collapse, a primary epiglottic collapse, then obviously any kind of supraglottic epiglottectomy or a supraglottic epiglottic bulgarization is something which will keep the epiglottis away from your airway. So this is again a very simple no-brainer. So the right patient then, who's that right patient? Like I said, the AHI does not matter. You have to make sure he's not a central OSA patient. But to say all that, you must have some understanding of a sleep study. And if a sleep study is inadequate, please rubbish it away. That's not the sleep study that you have to use. And you can consider that inadequate when anything which is less than 50% of that study, the probes have not shown anything, neither the oxygen saturation nor probably the airflow. So that is a study that you have to probably rubbish away. The anatomical sites is what I just spoke to you about. But the important thing here is the patient factors now that we have to discuss. Now, this looks very general, right? But these are the ones that we need to concentrate on. And these could be for any surgery, ear surgery, the counseling, expectations, comorbidity, probably general for all of them. But here is where the age and the BMI comes into the picture. So an age beyond the age of 65, where a patient has lost its muscle tone, his or her muscle tone, is probably not a very good idea for us to get into any kind of reconstructive surgeries. Right? That's the time when you probably look at other options that are available. But the age can be anywhere from 2.5, 3 years where we do adenoidectomies for pediatric OSA. So there's a huge gamut of age that is available. That's why the number of patients and the patient base for OSA is very high for surgical intervention in those cases. BMI, of course, is very important because anything beyond a BMI of 30 is probably not an optimal BMI for you to do it. I'm using and choosing my words very carefully. It's not an optimal BMI, does not mean that certain cases which really require to be intervened. But we are not here, and I'm not here to talk about exclusions. I'm talking general so that people will be able to go back with a better understanding of OSA. So the right patient is one who understands the concept of treating OSA and not just come to you for snoring and says, get rid of my snoring. His comorbidity should not put him at a higher risk than the procedures that he undergoes. That's extremely important. And there's a patient who chooses to want surgery rather than CPAP. He's the one that you need to be selecting for your work. And of course, anybody as a potential litigant which we encounter during our counseling is somebody I would stay away from. And he has to have obstructive apnea and not central apnea. His expectations need to be right, or they need to be set right by you. That's very important. You have to consider anybody and everybody in between the BMI of 23 to 30. Anything above that, I would put a word of caution on that. But like I said, make him earn his surgery from you, because if he is not willing to change and modify his lifestyle, he is the one who is going to give you a bad reputation in the future, even if you do touch him. And age preferably less than 65 is probably the best way for us to intervene. So now, understanding that and understanding the right surgery, this becomes very child's play. This is absolute child's play. A person with turbinate septum, go ahead and do that. Person with SP fold, do a coblation channeling. A patient with tonsil adenoids, do a coblation adenoid and tonsillectomy. A patient with palatal issues is Marco's barb suspension pharyngoplasty. That is absolutely doing wonders right now. And the right patient with tongue-based issues, like I said, coblator channeling or excision, depending on your expertise and the patient's choice. But it's not an epiglottis, like I mentioned, epiglotectomy. But it's not just about the patient and the surgery. The OSA surgeon also has to have his concepts very clear. And this is where I think a lot of work still needs to be done. Your concepts have to be clear in the sense of being able to identify the right patient anatomically as well as personality-wise. We'll keep personality aside because that is common for every surgery. But you have to be able to identify that anatomical site and counsel correctly. Again, that is by far the most important. Maybe it's also important, it is important for every surgery as a surgeon, but it is by far the most important in this less understood disorder of OSA, and that's why your counseling makes a tremendous difference to your surgical results. You have to have that expertise. You must travel places, you must pick up on people, you must identify newer techniques, you must get out of that mindset and say, oh, this works for me, so I'm very happy with this and I'm not going to proceed beyond this. And of course, as is common for every other surgery, you should know when to intervene. Optimal BMI in OSA plays a major role. When not to do, what not to do, just like any other mature surgeon would say to you, you have to continue to go ahead in every field of surgery, know when to stop. But this is a concept in my last few minutes, because I've given the additional time for our organizers. We know how difficult timing is, and if anybody overshoots, then we have a problem. So this is the concept of one major and two minor. And you see here that septoplasty has been slotted as minor, because a lot of us no longer pack the nose, but even if you do pack the nose, you have an airway along with an Avalon. I'm just showing you because it doesn't look that bad to have an airway with an Avalon pack. I'm not showing you because the technique is difficult. But you can pack both nostrils together with Avalon, post a nasal surgery and a palate surgery, and you will see that on table, immediate extubation, patient is absolutely fine. Keep in mind the BMI that you're dealing with. But the idea is that nowadays, septoplasty, since all of us do it so regularly and has no packing at the end, we use quilting sutures, you don't need to pack the nose is open. So any kind of surgery along with the septoplasty is not a major anymore. So you look at this, you have the palatoplasty, which we now are looking only at Marco's, we have the tongue-based excision or epiglottis. These are the only three major ones. And you can combine a palatoplasty with a turbinate channeling, you can combine it with a septoplasty, you can combine it with adenoids, you can do the channeling procedures. It's all there for you to now pick and choose, because you know that it's one major and two minor. That's how you go about doing the whole thing. Now this is the most important concept of management, the multi-stage single level approach. Because you have obstructions at different level, you ensure that you try to tackle each level differently, because the dynamics of the airway completely change. The dynamics of the airway change when you are doing and removing one obstruction from the other. So when that happens, if you give about a month or 2 months time between the first procedure and the other, then obviously a lot of things can change and a lot of surgeries may not need to be done. There is obviously, like I told you, this concept because of the present day scenario when you are doing a niche practice, or when all of you all are tackling medical tourism in major metro cities, you will not be able to have that patient coming back to you every 2 months or 3 months. So you must develop the concept of a single stage multi-level approach also, and this is where there is a very strong role of DICE. This is in fact the only place where there's a very strong role of DICE, because you would not want to plan any surgery without knowing the entire airway intact and counseling the patient whether he would also need to do a tongue base or an epiglottis also along with that. So if we have to now reflect back and see where is the role of DICE in OSA management, it's there in the single stage multi-level approach. In a multi-stage approach, when you have already finished with your palatal work, then that is a good time for you to look at what you've missed out at the epiglottis or the base tongue, provided the patient has not been improving. And to a surprise, many a times you might find the patient to have improved, and then that will not probably be required. But that's where there is a role. In revision cases, definitely DICE is needed as the first. You need to know why there has been a failure in the surgery. And in today's date, of course, because of the insurance-based documentation that we need, it is always required to do that. In spite of all that, you will still have patients like this sometimes come up to you. It's a very high BMI, HIV positive, on dialysis, not at all happy with PAP therapy, and had approached me for that very reason, that I'm not happy with PAP therapy, what to do. These are challenges that would come once in a while, and the only option that you can offer them is a tracheostomy. Now, I did offer the same thing to this patient, and honestly speaking, he didn't take my advice. He said no tracheostomy. But I think probably what I did was, with the counseling, this patient went in to get his mindset changed to start using CPAP better. He went in for weight reduction. He's still waiting for the for the renal transplant list to take him on. But he's been regularly following up with me for the past 7-8 months and has lost weight and is doing much better. So I guess I didn't need to operate on him, but he's still doing better, just because we are able to tell him something and make a life-changing attitude to himself in his life. Tracheostomy also has one other major role. So it's like a bomb that we're dealing with because of our airway. And you do a tracheostomy, and you can then very safely go ahead and do whatever surgeries you want on the upper part of your airway. You do the nose, you do the palate, you do all of them in one sitting. Also, the patient is absolutely fine. He has no problem with that at all. And that's where you can then you can close the tracheostomy later on, and this helps that patient very well. So, well in time for what I wanted to put out, very concise and precise messages, that OSA is just not about doing a sleep study and a DICE. I feel the DICE is really being overused by a lot of people who are not understanding the concepts, and they land up doing a sleep study and a DICE and then thinking about what next to do and how well to go ahead. So if it's a multi-stage approach that you are planning on, which is what will happen to you in most patients, because very few will actually want to get involved with a single stage multi-level approach. In those kind of patients, if you do your counseling well, and if you plan your treatment protocols well, you don't need to really do that DICE initially. There is a huge paradigm shift now, right from the surgeon-centric approach to a patient-centric approach. Like I said, it's not about you. It's not about the surgery that you can do so that you can put up big videos, or you cannot or show up some kind of great stuff that we do, because this is palatal work. And palatal work, and to a certain extent work which is not very technically difficult or challenging like most other surgeries are. One must understand that. I wouldn't say OSA is a very challenging surgery, but the decision making is the challenging part here. So you have to understand this major concept, that it's a dynamic change. So you know the Bernoulli's phenomena. If I clear up the nose, the entire pharyngeal collapse would change. There's a dynamic change in the airway flow that is happening, and that would probably lead me to a different decision at that time. So I would not want to do everything. It's the story of the monkey and a banana, where you eat up the whole banana at one shot, or you go stepwise and take that step. So the stepwise approach is probably the most logical one, unless of course logistics dictate it otherwise. And surgical decisions, which were the confusing ones, which everybody kept saying, why do I have to, think, why not do this surgery, why not do that surgery, even this is available, that person does this and this person does that. And especially when you attend a lot of surgical workshops where different faculty has demonstrated different techniques, and you come out of there and you suddenly don't know which technique to use where. But that was then, and this is now. Now we have evidence-based changes that are happening, and you have a workhorse which probably deals with the entire lateral wall as well as the suspension, and you have the upper airways which are very easily then cleared off. I cannot overemphasize the role of the MaxFax and the dental community in this. There's a huge role, and it's not just limited to maxillomandibular advancements. Up till now, people would only think that the role is in the MMA, that whenever you have a bony box issue, you do an MMA and you get away with it. No. They have a tremendous role to play right from the initial stages of evaluation, where if you evaluate the bony box correctly, even non-invasively, they will be able to open up your airway to a very large extent. And you must coordinate with them, get them involved with your treatment protocols. I've already mentioned this. Like I said, treatment is just not about surgery. It's how you approach that patient. And a very, very simple, proper counseling can be life-changing. It can be a game changer for that particular patient, and you will have done your bit. So, ladies and gentlemen, I would like to leave this hall today, leaving you thinking, oh, OSA, what's the big deal? I can also manage OSA and snoring. It's no great shakes. A complete pun intended in that. So what we have changed, we have come from 2004 to 2024. What I've told you is what exists today. It's evidence-based, and this is what is happening in the world right now, not just in our country. But maybe 10 years later, somebody else giving an oration on an OSA or giving a keynote lecture on OSA would probably rubbish me away like the way we've rubbished UP3. That is a huge possibility. That's what science is all about. So we must keep that in mind, and I would like to leave you all with just a very simple few lyrics from Sahir Udhanvi that gives you my philosophy in life per se. Can we have volume, please?
तुमसे बेहतर सुनने वाले कल कोई मुझको याद करे क्यों कोई मुझको याद करे मसरूफ जमाना मेरे लिए क्यों वक्त अपना बर्बाद करे मैं पल दो पल का शायर हूँ.
Thank you very much, sir. And extremely, extremely honored to have been here. Thank you very much.
That was an excellent oration on the OSA, highlighting about the patient-centric approach, the BSP, then the RF tunneling and coablation tunneling of the base tongue, and regarding the dice, importance of the dice and when it should be done. That was very much summarized very well, sir. And I think a lot of delegates have definitely been enlightened about the OSA comprehensively. Thank you so much, sir.
Thank you very much for a wonderful lecture. Sir, the title is very catchy. The right surgery for the right patient. So he's a right orator for the right oration. Thank you very much, Seemab. It was an excellent.
Thank you, sir. Thank you so much for having me here. Thank you all. I think I would prefer that we go down to Madam rather than come her up.
Yeah. Yes.
We'll come down now.
Seemab. Madam is coming up on the wheelchair. She'll put the medal around and she'll need to talk for 2 minutes.
so much, Dr. Sheikh, of giving such a wonderful, extensive talk about OSA. My dad was passed away before all this started. All your new modalities and so many different surgical treatments. But he and his colleagues at that time, they did try and do something like septoplasty, adenoidectomy, tonsillectomy, uvulectomy. And he would have really loved to hear what you've said today and how much difference it can make. Yeah, thanks a lot. I would also like to thank the organizing committee and the AOI for having given me this opportunity of addressing you all today. I'd like to tell you one small thing is that in 2002, we had the AOI in Bangalore. It was not Bengaluru, it was Bangalore. And Dr. Medically was my organizing secretary. And I was president of AOI. Everyone said that was the best conference ever because we had 15 foreigners talking and 5 or 6 of them operating live. Of course, that can't be any more, but as I see from this program, Dr. Sunil has made it even better, and I'm sure next year, Dr. Milgiri will make it even better than that. So with that, I wish all of you all a very happy and prosperous New Year, and I wish the rest of this conference a big success.
I'm going to read out the citation. We, the office bearers of the Association of Otolaryngologists of India, are proud to have been associated with you. Your determination to make a difference in the society and your commitment to the field of ENT has earned you the respect of your peers, colleagues and juniors. Your relentless and perseverable work, along with your teaching capabilities and your sympathetic approach towards your patients has made you a role model to others in the field of ENT. Your exemplary zeal to go out your way to help your patients for each case of approachability and your desire to teach the younger generation makes you one of the most admirable personalities in our fraternity. We are fortunate that you have accepted to deliver Dr. Jovi Desa Memorial Oration on the topic obstructive sleep apnea, the right surgery for the right patient at the landmark Platinum Jubilee 75th Annual Conference of Association of Otolaryngologists of India held at Bangalore from 4th to 7th Jan 2024. We are very grateful for having bestowed us with your presence and illuminated us with your immaculate, vibrant and articulate lecture on this topic. We hope to see you more of your work in the future and wish you the best in your endeavors. Thank you so much, Dr. Seemab Shaikh.